Can I? Merci. So, continuing in the story of trauma, for those of you who were present in the previous case discussion, I have the pleasure now to introduce you Chiara Robba from Genova, who is a worldwide expert, despite the smiles, and this is true, on the management of patients with acute brain injury. And Chiara, you know that there's also big interest, thanks also to your previous boss, Paolo Pelusi, that I also remind a lot in the meetings, an interest mechanical ventilation. So, perfect case, we combine RDS and TBI, and we will have some questions for you. Chiara, please.
Okay. So we prepare this together, and so we want this to be very interactive. So we have a 56-year-old man who was previously fit and well. This is the shin. So high energy trauma. Road traffic accident. On the scene, he had a GCS of 8 with M5. Pupils equal and reactive to light on site. He was very, very much agitated, and he also had signs of chest trauma with dyspnea. His SATS was around 85%, despite an FiO2 of 100%. He was intubated on the scene, and then he was transferred to the hospital. On admission CT, what do you see?
If you see something.
If you see something.
Yes.
There's a temporal contusion.
Well,
and swelling, of course.
There is a contusion and a diffuse swelling. So this is not a patient who requires a neurosurgical intervention, at least in the first phases. But considering the GCS and the CT, the neurosurgeon inserted an ICP probe. He had ribs fractures, and this is the CT of his chest. Contusions, and don't underestimate this. He had a lot of fluids during the resuscitation phase, which to me are clear in this CT. And this is the situation on ICU admission. So he's sedated, intubated, he's on propofol and fentanyl. At the moment he's normothermic, he has no fever. ICP is quite unstable. You can see from the waveform that P2 is higher than P1, and you cannot eventually see the difference between the two waves, with different spikes to 22 to 25 millimeters of mercury. This is how he was ventilated, pressure-controlled ventilation. The PEEP is debatable, but in this case it was set according to the PV tool and according to the response to PEEP trial. And it was initially set around 10 centimeters of water. Plateau 27 with a driving pressure of 15 and a tidal volume of 350. So low compliance. To achieve a plateau pressure of 27, we had to use tidal volume of 350, which for him is about 5 millimeters per kilo predicted body weight. Arterial blood gas, 77 of PaO2, 47 of PaCO2. pH still in range, but at the lower limit. Not too bad, the lactates, electrolytes more than acceptable, PF 150. Come on.
So that's the question. Is the patient suffering from RDS? And, well, that's a little bit of help. If yes, why is it important in case of TBI?
And why it is a further problem?
Who thinks that the patient has RDS? You can just raise your hands.
Well, it's the name of the case, so...
So those who didn't raise the
they
hand,
can go in the other.
I have not a question myself. You were there just by hazard, okay? So why is it important? Why is it important having RDS in TBI? Yeah.
Where was
The bottom of the scene.
Thank you. Well, it has all kinds of implications in oxygenation, in ventilation. So we will not be able to maintain protective ventilation and implicate the measures to control the intracranial pressure, probably.
So
True.
you mentioning the arterial blood gas. So when you do protective ventilation, okay. What is the other issue that might be relevant?
Ike PEEP, okay.
It's just higher PEEP decreases return of blood from the brain.
So it's arterial blood gas and lung mechanics.
Is CO2 a concern?
CO2 concern.
Essentially.
So arterial blood gas, that's the point. So you mentioned arterial blood gas, oxygen, CO2 particular.
So from the lung point of view, I will be even happy with that
Yeah.
ABG because the pH was quite preserved. But from an intracranial perspective, this might be an issue. Okay.
Also, the complications of setting a PEEP in such patient may be reflected on his hemodynamics, leading to decrease in pulmonary infusion and CNS perfusion as well.
Yes. Also because I gave you a tricky information initially. I said fluid overload. So if you have a patient with a ERDS, you really want to keep him dry. As you know, regarding fluid balance, even in brain-injured patients, we should not use positive balance. But for hemodynamic stability, if we want to achieve very negative balance, might be a problem because we need high PEEP, we have a high intrathoracic pressure, and so the patient may become hypotensive. So what you said is basically what is described in this nice slide from Paolo Pelosi and Patricia Rocco. There are different hypotheses regarding the interaction between the brain and the lung, which are also related to inflammatory mediators. And here we have an expert on this. If you see patients with TBI, if you have experimental studies where you increase the intracranial pressure, you will have an increase of extra lung vascular components. So regardless of the presence or not of ERDS, if you have an increase of ICP, there is a pulmonary damage. But then, if you think about all the things that you can or should do to treat the brain or the lung, these are often in conflict one to each other. This is a nice meta-analysis. ARDS incidence in patients with brain injury, very common, 20%. I have to acknowledge one thing. I think there is a huge difference between the incidence of ARDS in brain-injured patients. It's a temporal difference. 20 years ago, it was also up to 30%. Here, these are the latest data from the Venio study. It was just 3%. What do you think has changed? For instance,
The way we ventilate patients?
the way we ventilate the patient.
What else? What else have changed? You indicate him. It's like at school. Amazing.
Fluid management.
Fluid management. Fluid management has changed. Very good point. What else have changed? The patients. I mean, 10, 15 years ago, we had mostly young people having car accident. Now we have half of patients who have fall down, elderly people who have a general domestic accident. So the mechanism makes that probably there's less polytrauma and
Now we
less
see
RDS.
less extracranial complications because it's the population of TBI patients which has changed. But just to give you some number, in 2000, in the early 2000 years, the 35% of the patients were ventilated with ZIP, with zero PEEP. My boss would go
I
crazy.
still do see. Sorry.
And 1/3 of the patient had a median tidal volume of 12 milliliters per predicted body weight. So, of course, this importantly affects the effect. So, let's move on. How do we manage it? Because someone talked about the targets. Okay? Here you have strategies regarding acute brain injury, and here about ARDS. Look at the targets, the ventilatory targets according to the guidelines. And of course, I'm talking about two different guidelines. There are guidelines for ARDS, there are guidelines for TBI, there are no guidelines. We tried, but we gave no recommendations. So, in ARDS patients, the target might be also between 55 to 80 millimeters of mercury of PaO2, and PCO2, it's not a big deal as long as the pH is preserved. Do you think this is acceptable for a brain-injured patient? At least it's difficult, no? Fabio, physiology.
You want me to tell? Yes. So the first thing about the PCO2 and PO2 is that now that we monitor brain oxygenation, we know that there is a huge association of tissue hypoxia with low levels of PO2. So now we know it. We didn't know it in the past. And of course, you don't want to add a secondary insult. So that's why in the guidelines you see 75, 80 is PO2 and not 55. The second point would be PCO2, or some of the slides you will present thereafter. So you remember the effect on PCO2 on the brain, vasodilation, increasing the arterial component. For the Morrow-Kelly low, you will increase ICP. So these patients who have 22, 25 spikes, I don't know if it is brain swelling because of cytotoxic edema or brain swelling because of a little bit of component vasodilation. And the third point, I think you mentioned lung mechanics. So you remember that 70% of the blood into the brain, don't forget, is venous. You have big veins drinking the blood back to the jugular vein into the thorax. Each time you apply a pressure that makes resistance to the outflow of the brain, you will increase the venous component. This is true for PEEP. This is true for the position on the bed. It's the same we discussed in the previous case. And this will potentially then increase secondarily intracranial pressure. That's basically a summary of what we discussed recently. So everything basically matters in terms of brain hemodynamics when you consider lung mechanics and ABG.
Okay, so let's see what the guidelines say. These are the very new guidelines from the ESIC, from Giacomo Grasselli and colleagues. What they ask is to use low tidal volume, to use plateau pressure below 30, if possible between 27 and 30. No recommendation on how to set the PEEP. I mean, there is not a strategy that is recommended. As I told you before when I said it is debatable, many don't like the PV curve. It has some limitations. I still use it, but then I look at the lung mechanics basically to set the PEEP, and I do the PEEP trials. But as someone was saying, doing a PEEP trial in a patient like this might be challenging. These are the guidelines for the mechanical ventilation in acute brain-injured patients. First of all, look here. No evidence. So basically, most of these recommendations were based on expert opinion. It was 2020, so 4 years have gone, and I think something more has come out. The first recommendation is, if a patient has not a problem with intracranial pressure, with intracranial hypertension, the level of PEEP should be maintained at the same level as you would use it in a patient without brain injury. We recommend lung protective strategies even in brain-injured patients. This is changed compared to the past. So the concept of plateau pressure and tidal volume, here we did not discuss the driving pressure, which I think if we do again the guidelines we should take in consideration, but plateau pressure and tidal volume are priorities even in brain-injured patients. Why? Because if you're not protective with the lung, you make higher the chances of worsen the respiratory mechanics, and therefore you pay the price in terms of arterial blood gases and hemodynamics. Regarding the PEEP, someone said too much high PEEP is detrimental. True. My question is, what is too much PEEP?
I bet it will depend on how the right ventricular function is, and partly.
So it's the effect on hemodynamics. It's true.
Absolutely.
This
What
effect,
else?
it can be the effect on the lungs, by the way. You increase the PEEP and you will see that you start to
But
reduce
true.
brain compliance.
This is what came out from this study.
Yes, actually, this is a matter of much debate. What is the best PEEP in such cases? Because it's a complicated effect, either on the atelectasis, on the shear stress and strain on the alveoli itself. So, as a matter of my opinion, in my unit, we adjust the PEEP in such cases that keeps the hemodynamics and preventing the over-distension of the alveoli reflected on the SpO2. So it is variable from patient to patient and from time to time, not fixed figure.
I think it's a fair point because we try to see at the meetings people giving you an advice, but as you know in medicine there is one advice working for everyone. So an individual approach, and then sometimes the decisions are contradictory. You might improve the lung, but have detrimental effect on the heart, and then you have to find a compromise. So it's a matter of testing.
This is exactly what you said, is exactly what is described in this physiological study. This is a quantitative CT. Of course, this is just for understanding the physiology. We cannot do it at the bedside. There is ultrasound, but it's different. Quantitative CT of the lung means that with different level of PEEP, we calculated the weight of the different parts of the lung. And with this software, we were able to assess when an area becomes hyperaerated and when one area is recruited. Okay? From the result of this physiological study, in fact, what we found is that PEEP does not increase ICP as long as it doesn't start to hyperextend. So if the PEEP is enough to open the alveoli, you have an improvement because you have an improvement of the compliance. And this does not result in an issue with venous return and improves oxygenation, obviously without affecting hemodynamics. Finding the right balance is obviously difficult, but the concept is that we should not be scared. When we discussed this with Gattinoni, he said, well, we should put in all brain injured a transpulmonary catheter, a esophageal catheter. Probably he's right, because it's all about transpulmonary pressure, if we think in this...
It's the transmission of what you give to the lungs to the vessels, and then to the brain.
The other point is the CO2. Because, as someone of you said, CO2 is importantly affects the diameter of the cerebral vessels. Okay? So, permissive hypercapnia is a problem for brain-injured patients because it gives vasodilation. So, in a patient like this, where we have set all our ventilatory settings mechanics, then we have to start to treat the ICP. What can we do? Let's assume that we have done all the tier 0 therapies, which are maintain the physiology, normal blood pressure, electrolytes are fine, the patient has no fever, okay? The guidelines say, okay, if this doesn't work, there are some things that you can do. In a patient with ARDS, you can keep CPP a bit higher, increase analgesia and sedation, and this is something that actually we can do. We can give mannitol or hypertonic saline. Yes, in this patient we can do it. We can discuss with a neurosurgeon whether there is the indication to put an EVD drainage. Yes. What I find more difficult is to target a CO2 of 32 to 38.
This year one, it is if we have NIRS and there's a decrease in oxygen, cerebral oxygenation, then the PCO2, it's permissive to keep PCO2 42-ish. right? So, and I saw that the PCO2 for this patient was 40 something. So my point is, if we have NIRS, the guidelines, because this is a guideline only for increased ICP, and there's a guideline, as you know, for ICP plus, yeah.
So having brain oxygenation could be. So you want to say that you would not change the ventilators because you would tolerate 22, 25 if ICP is a bit slightly elevated, but the oxygenation is fine, which is, probably possible because if you vasodilate, you have more blood into the brain, you might have probably enough oxygen coming there. It's maybe we won't discuss the pitfalls of
NIRS.
NIRS because it's long. It's one we have a discussion on NIRS on Friday if you want.
Yes.
But that could be possible. Yes, yeah, that's
But
one.
let's say that ICP is still spiking and that this is not enough. What the guidelines ask is to put our patient at 32, 35 of PaCO2. In a patient with ARDS, I think it's quite difficult. Other things, MAP challenge. Do you know what the MAP challenge is? And eventually neuromuscular paralysis. The patient is worsening. We are at the tier 2. So we have done all the things that I showed you before except with PCO2 because we were not able to reduce the PCO2. And to answer your question, in this case we had the PbTO2, so cerebral oxygenation, which is quite low. We optimize HB, we optimize CPP. The PEEP was increased to 12 according to the respiratory mechanics. Plateau pressure 30, so we are really at the threshold of the guidelines, and this is worsened. With 30 of plateau, we have now 300 of tidal volume, and the driving pressure has gone up to 18. So, not bad, not good. Neuromuscular blockers, would you do them? I agree. In fact, also in the meantime, the arterial blood gas is getting worse. We are far from the 32, 35 millimeters of mercury of PCO2. The oxygenation is getting worse. The PF now is less than 100. All the rest, this is even too much, probably, because we were probably giving him a very negative fluid balance. Electrolytes acceptable. Lactate still fine. We repeat the imaging, worsening of cerebral edema and progression of a contusion. This is a bit changed. Looking at this CT, if this was not a brain-injured patient, there is something I really would like to do. What would you do on a CT like this? From the lung perspective. PF less than 100.
I don't know. Could it be because because the parameters of the ventilator you cannot change them that much because it was already almost damaging, let's say. But could it be possible to put the E-core device to extract the CO2? So CO2 extractor.
So you go for extracorporeal, yeah. I have a question. Any one of you would increase the respiratory rate? Because if you calculate, we have 300 milliliters times 22, we have 6 liters meter volume. It's not so high. It's 22 respiratory breathing is 22 times 300 is 6 liter. You will go from to what? To 30? Okay. Well, what I want to say is that if you go to 22 to 30, I would do the same, but as the patient is worsening, you would use as, gaining some time because ICP is very high. I will not keep at 30, 35 for a few days because, if the RDS is decreased, it's not because you are hitting on the lungs more frequently that you will go from 52 to 35 PCO2. You can maybe gain a little bit just to stabilize the patients, but just to mention that in some centers where, Echo 2R or other stuff are not available, you might go for a higher respiratory rate.
Yes, but keep in mind that even increasing the respiratory rate might be dangerous for the lung.
Yeah, it will increase the dead space. Again, it's a matter of...
If you remember, well, the formula of the mechanical power is as long as this, but there is a simplified one, but there is the respiratory rate, okay? It's a work for the lung. So I agree with Fabio that I will try, but not as, let's say, only as a temporary measure.
So if you were in the RDS session, can you go back to the CT scan? And you have this kind of patients with the PF on 100, already on...
Let's imagine that he has
people
no
from
brain
France,
injury.
what do you do? I mean, come on. French guy, okay.
Prone position.
Pro. Okay.
Okay. But of course, we have to think a bit more in this patient. Do you agree? What can we do? We have done all this. This, we were not able to achieve it. We did the map target, the map challenge, but it didn't actually work. These are the guidelines from the ARDS guidelines regarding the routine use of an MBA. They are against the routine use. In this case, I will take absolutely the risk. It's part of the two. We use them probably a bit earlier if you consider the staircase approach, but I will definitely go for it. We did not discuss the recruitment maneuver. Would you have tried it? These are the guidelines for ARDS.
Everyone says no. No one would try recruitment maneuver.
Against. They are against the routine use of the recruitment maneuver. And in 2020, we did not find an agreement, but I will say against. The hemodynamic effect of the recruitment maneuver, honestly, is not worth it, the effect that they haven't proved. So, no recruitment maneuver, these were not tried. Prone position. With prone position, the evidence are completely different. Grasselli says we recommend prone position, and also compared to previous years, they recommend to do prone position quite earlier than before, and for a longer time. It works, it improves mortality. In our guidelines, so mechanical ventilation in brain injured patients, we recommended to consider prone position. Okay, there are not strong evidence, but increasing evidence which say that if you are careful on the position, on the monitoring, etc., prone position can be a good option. But of course it's scary. You have a patient with unstable ICP. How would you prone it? This is a physiological study on recruitment maneuver and the effect on cerebral oxygenation. These are data regarding prone position. If you are good in maintaining the hemodynamic stability while you prone the patient, you have no changes in the arterial blood pressure and in the CPP, and improvement in systemic and cerebral oxygenation. So this is the effect they do. Of course, you have to be careful. So I don't know what you do in your units, but in my units, if a patient is not brain injured, we keep him like this. If a patient has a brain injury, and probably it's a mistake because sometimes they have, we start to see a lot of complications. In a patient with brain injury, be careful. First of all, to the neuromonitoring. Secondly, no, it's true. And third, to the intra-abdominal pressure.
I have also to make another comment. There are a lot of data on oxygenation improvement on prone position. As Chiara just showed, the effect on PaCO2 are much less predictable. So you might have a recruiter in terms of oxygenation, but you may go from 52 to 50 or 49 PaCO2, which will not solve our problem of ICP. So it will be better for the lung, but if the problem is hypercapnia, not hypoxemia, it's hypoxemia, of course, but hypercapnia could not be just solved just by prone positioning, unfortunately, or will take a lot of time to be really improved. Yeah. So what else remaining? Someone said échautoir. Other questions? Yes.
Thank you. We have, I think, satisfactory experience with the improvement of oxygenation with prone position. But as you said, reflected on this PCO2, it is disappointing. And in my opinion, the guidelines is not in favor with that, except with caution getting into the PCO2 as well.
Exactly.
So here my question is, why not trying to decrease the intracranial pressure by shunting on something like that in order to make a positive effect on both the lungs and the brain as well?
When you say shunting, is extracorporeal shunting?
Yeah.
Or? I think Chiara made the point here. I don't know if someone has thought to this possibility. What happens to the PCO2 if you cool a patient? Goes down. CO2 production is decreased. For the same minute ventilation, PCO2 will go down. So if you just look at the effect of PCO2, has been shown in RDS in 93. Improve oxygenation, reduce CO2. But
This is the ICP with hypocapnia, which was induced by the increase of the respiratory rate, and this with hypothermia. So the effect is...
so you might consider, at least if the patient is 37, to cool down to 36, maybe 35. Be careful about, the effect on pH and temperature and the affinity of the oxygen to hemoglobin, because you might really decrease the release of oxygen from the hemoglobin. So you might end up with some degree of tissue hypoxia despite you reduce ICP. That's one possibility, maybe. But
So there is not a correct answer to this condition. There are two perspectives, because from the brain perspective, we should go for the tier 3. So hypothermia, we can try it. It's worth it, probably in this case. Decompressive craniectomy. But then if I want to prone the patient, or then if I want to put him in ECMO, I will think it twice. Barbiturates. And then there is the lung perspective, where now the guidelines say, well, if all these did not work, consider ECMO. They are against, for who was asking, SCCO2.
And I would say that the problem with ECO2R is that you need to fully anticoagulate the system. At the flow that you use today, it's difficult to say, ECMO, if you put a VV ECMO with 5 liters output, you may go with very low anticoagulation targets. With the patients with a TBI, you might be concerned about full anticoagulate. That's why, and if ever it becomes hypoxemic, you have to shift from ECO2R to ECMO. So personally, I would go for VV ECMOs.
And in fact, this is what happened in this case. These are some new evidence, growing evidence on the fact that TBI is not anymore a contraindication for ECMO, with some considerations, the priming of heparin, the dose, etc. But in this case, we decided at the end to put this patient on ECMO. But again, there is not a correct answer. This is what we did, and these are all the things that we have considered in this case. The compressive craniectomy, for sure, someone said it, could have been an option, in my opinion. ICP becomes more stable, so I have no more problem maybe in permissive hypercapnia, because my ICP is more under control. But then there is the risk that if I have to prone the patient, if I have then to start the ECMO, the patient might bleed, the patient might have complications. Hypothermia and barbiturates, why not? We discussed already the hypothermia. Let's take in consideration the systemic complications of barbiturates and hypothermia. We have a patient who is already very sick, high risk of infections, so it's debatable. Prone position, with a chastity like this patient had, the idea to prone him was very, very strong. But again, if it gets complicated from an intracranial point of view and he needs a decompressive craniectomy, what are we going to do? And then the venous-venous ECMO allows us to use lung protective strategies to reduce the PCO2, to improve the oxygenation. Of course, there is a risk of bleeding, because there is. As mentioned, this patient was put on venous ECMO without the priming dose of heparin. he started very ultra protective ventilation with PEEP around 10. It's another issue here. Progressively, the intracranial situation was improved. The CO2 we were able to target the CO2 to 32 to 35. From an intracranial perspective, it was more and more stable. And afterwards, it was weaned from the ECMO, and the patient went fine. So, I think that the things that we have discussed today can be summarized in this editorial, which this is a picture which is not easy to understand straightforward. But here you have the 3 tiers for ICP monitoring, and here you have all the ventilatory strategies that you have to use. In one word, my opinion is that there is a staircase approach for ICP management. There is a staircase approach for ARDS management. If we put them together, it's not a staircase anymore. It's much more complicated. Sometimes you have to make choices. From the brain perspective, you might have to skip some steps. From the lung perspective, you might have to skip some steps. But at the end, there is not a magic formula, and we have to make decisions.
So as we are 5 minutes late, there is another session after us. Again, thanks, Chiara, for the nice case presentation. Thanks to you. For me, it was a real pleasure to have 2 sessions with clinical case on TBI. And so enjoy the rest of the meeting. See you.